Good morning, dear audience. In my PhD work, I'm focusing on improving postoperative outcomes after cardiovascular surgery. My name is Nikolett, as the dear chair already introduced me. I'm a specialist in anesthesia and intensive care at the Heart and Vascular Center. My vision is for science to prevail over routine, and for that I would like to implement standardized perioperative protocols in cardiovascular anesthesia to minimize postoperative complications. I have two projects. The first one is a meta-analysis in the field of cardiac surgery. And the second one is planned to be a randomized clinical trial for vascular surgical patients. The first project is investigating the predictive value of urinary biomarkers in cardiac surgery-related acute kidney injury. We know that acute kidney injury is one of the main complications after cardiac surgery, and it accounts for a great increase in mortality after this surgical procedure. Its early recognition is essential because we only have supportive measures to treat these patients with acute kidney injury, but we don't have a specific cure yet. We use the KDIGO criteria to diagnose acute kidney injury, not only in cardiac surgery, but in other fields of medicine as well. This is a diagnostic tool, but not a predictive tool. Urinary biomarkers have been widely investigated in several critical conditions because they are released as a signal of renal stress or early damage much earlier than the actual loss of function develops. What we don't know if their performance is satisfactory in case of cardiac surgery-related acute kidney injury. So therefore, our aim will be to determine the diagnostic accuracy of urinary biomarkers in cardiac surgery. If we are able to identify high-risk patients earlier than their actual loss of function or loss of kidney function develops, then we are able to implement preventive measures, thus decrease the development of AKI. So our hypothesis is urinary biomarkers can accurately predict the development of AKI. We conducted our systematic search, and after the full text selection, we've arrived to 86 plus 3 articles. We were unable to retrieve 3 articles. We included 79 articles reporting on 11 different individual biomarkers in our quantitative analysis. Today I'm going to show the results concerning individual urinary biomarkers, the combination of 2 or more biomarkers, and the predictive ability of clinical models and score systems enhanced by urinary biomarkers. Our primary outcome is the prediction of all stages of acute kidney injury. The secondary outcome is prediction of severe acute kidney injury, which is stage 2 or 3. The outcome measure will be AUC with 95% confidence intervals. On the first figure, you can see the L-type fatty acid binding protein urinary biomarker. Its predictive value for all stages of acute kidney injury after cardiac surgery. I'm showing this individual biomarker because it has the highest predictive value among all the investigated biomarkers. You can see that the highest AUC is 0.75, which means that we are able to identify 3 or 4 patients out of 5 with this biomarker, which is a fair predictive value. We performed subgroup analysis based on the urinary biomarker measurement times. So you can see preoperative, intraoperative, and postoperative biomarker measurement. For the stages 2 and 3 acute kidney injury, we found that the tissue inhibitor metalloproteinase 2 combined with the insulin growth factor binding protein 7 has the highest accuracy in case of the measurement which happens 6 hours after the surgical procedure to the postoperative day 1, but it still has a fair predictive value. Many articles report on the combination of biomarkers for prediction of severe and also for all stages of AKI. I'm showing here the highest prediction values. You can see that the highest achievable AUC is 0.87 in this case. From the postoperative 6 hours to the postoperative day 1 time points. In this case, we applied joint subgroup analysis. So in the first column, you can see the intraoperative measurements with 2 factors, so 2 biomarkers. And below you can see the same time, but with more biomarkers. You can also realize that there is a high risk of bias, which is usually because of the measurement inaccuracies. We were also curious if there is any effect of the number of the combined biomarkers on predictive accuracy, and we can see that there is none, basically. So they also, no matter how many biomarkers we add, we won't get a higher predictive value. We also investigated if the clinical models have higher predictive values for AKI, and we can see that already established clinical scores or locally developed clinical models have a fair accuracy, and if we add different biomarkers to these scores, it increases the accuracy somewhat, but still it's only a good prediction, and it does not exceed the previous combinations' predictive values. So the main strength of our study is that this is the most comprehensive study in the evaluation of cardiac surgery-related AKI predictor urinary biomarkers. The population is quite homogeneous because it's one surgical procedure. The limitations are the heterogeneity because of the biomarker measurement time points, and also articles included high-risk and low-risk patients for AKI, and also normal and impaired renal function. And also there is a high risk of bias. So as a conclusion, we can say that individual urinary biomarkers identify patients with fair accuracy for cardiac surgery-related AKI. The combination of urinary biomarkers provide good discrimination, and clinical models also provide good accuracy, but not as good as the combination of biomarkers. For implication for practice, we can say that a combination of urinary biomarkers should be used. And a main implication for research is that we should report on urinary biomarkers with a more accurate and transparent way. So we are still in the process of analysis, and we already started the methods for the manuscript. And for my second project, just a few words. It is going to be a perioperative liraglutide for optimal glucose control in aortic aneurysm repair. Thank you.
Thank you very much. A question, what do you think about the clinical use of these biomarkers alone or combination? Because many relatives come to you after an intervention that, what is the perspective? What is the future? They are lay people. They don't know anything about medicine. Do you think so that are we already in the phase of the development? Then we can use the message of this biomarker or biomarkers to tell the relatives, so, sorry, be careful because the prognosis is very poor, or it's too early to tell it. It's only for the medical persons.
Thank you. There is one biomarker which we can measure at the bedside, so we can actually use it in the clinical practice, and we can tell the relatives that this patient has a higher risk, this is the TIMP2, which I've shown, which predicts the severe AKI with a good accuracy or fair accuracy, but we can say that there is a higher risk. So probably that one can be used. All the rest is measured by ELISA, so at the bedside we cannot really say anything about it. It takes more time to have the results back.
But just to join the first question, it's measurable.
It's measurable.
Okay. What about the price? I'm just wondering. Sustainable medicine question.
Yeah, I think
I'm just wondering. So,
I think tertiary centers can afford the TIM2. That's a bedside kit.
Yeah.
And well, I don't know. I think in Hungary only one is available for measurement, which is the NGAL, and all the rest is not.
Have you tried that?
No.
You're a practical person, you're an anesthesiologist,
no,
so you haven't tried that.
I was waiting for these results if I should try, if I should go for my boss.
And okay, that's a good, it's a good answer, but I mean, and?
Probably I would try the TIM2 with some clinical scores.
How would it change your clinical practice?
If we identify the high-risk patients, then I think we can focus more on not giving nephrotoxic agents.
Yeah, but I mean, normally we don't like to give that toxic agent to a patient.
Yeah, but I think we are prone to give just a shot of vancomycin, just in case. For these patients, I would avoid that definitely. And also, the KDIGO recommendation says that we should perform a targeted hemodynamic therapy, and for in the rest of the world, they use Schwann-Ganz catheter for that. Probably it's a bit too invasive, but we can do that by echo.
Have you seen a single clinical trial which has proved the good idea of using Schwann-Ganz catheter just for tailored therapy?
No.
I haven't seen that either.
No.
With morbidity and mortality trial, I haven't seen that either. So that's a problem. We quite like to use it because we like it.
Yeah,
but I haven't seen a single clinical trial.
I have a question. Thank you for the great presentation. I have a fairly similar topic, and I was wondering, could you gather data on the geographic region of the patients? Because what I found is that the region had a way larger effect on AUC than the biomarker choice itself. So that may be a strong confounder in your case. I don't know. What do you think?
We haven't checked that, but now that you are telling this, there is definitely a geographic confounding on the choice of biomarker, and then probably on the AUC as well. Yeah.
Thank you.
Thanks.